Now, next we have a speaker who's returning to us, Dr. Sara Crager. Now, I was looking through her bio, and it's like a tick box of all the major American institutions. So Yale, UCLA, Stanford, back to UCLA. I mean, where's Harvard? I mean, honestly, it's terrible. I mean, she's missed a few things out, but she's a world famous international educator, specifically in ICU and critical care, and she's won multiple teaching awards. And it's my privilege to introduce Dr. Sara Crager to come back to us again today.
Hey everybody. I am an emergency physician and intensivist at UCLA. We're going to talk about the shock continuum, where I am going to try and convince you to think about shock a little bit differently. We have a blood pressure problem. Obsession even, I might call it. And this problem, I don't quite know where it comes from, but it's the one vital sign, more than any other, that we like to focus on. I mean, before COVID, we kind of liked the O2 sat better, but these days we're kind of blasé about it, like 80, I can live with that, 70, a little bit worried. Now it's all about the blood pressure. I mean, think about it. When somebody comes to you with any other abnormal vital sign, heart rate, O2 sat, anything, what's the very next question you ask? The blood pressure. Why do we love blood pressure so much? I think it has a lot to do with this. This is one of my favorite quotes. Measure what is important. Don't make important what you can measure. And we are especially susceptible to this in medicine. Why? We are care providers. We're physicians. We're nurses. We like things we can measure. We're tested on things we can measure. Things we can measure, we can say definitive statements about. Like, if the map is 66, they are not in shock. If it is 64, now they are in shock. We like definitive statements like that. The problem is our blood pressure obsession, our addiction to definitive numbers causes us to miss things, and not just anything. It causes us to miss things that matter. Because not all misses are created equal in medicine. I mean, if I fail to notice that my patient has a renal tubular acidosis, it just doesn't matter. Or a couple nights ago, I was resuscitating in the CTICU, and there was this patient, and they start bleeding, and they're like 500 out of the chest tube every 15 minutes, and we end up having, tamponade, and the CT surgeon has to open the chest at bedside, and then in the morning, patient's doing much better, and on morning round, somebody's like, yes, but did you notice for the last couple hours, the sugar's been almost 300? I was like, really? Come on, guys. That's just not a miss that matters. But some misses do. And most of the misses that really do matter, the ones that make the difference between your patient, either yes, dying or not dying, but more importantly, or at least as importantly, walking out of the hospital and going back to their life, or maybe leaving the hospital after a 3-month ICU stay, getting paked and tregged, paked and tregged, whatever we're calling it these days, and going to a long-term care facility are often the ones where speed matters. They're the ones that when matters, not just the what. I mean, if I take a patient with hemorrhagic shock and I correctly diagnose that they're massively hemorrhaging, but I do it 12 hours too late, I haven't really done anything useful. And this is where we get this idea of the golden hour. But we often talk about it in the context of trauma. Everybody knows this concept in the context of trauma. But I like to interpret it a little bit, because it's not just an hour. I mean, an hour is a nice amount of time, but some amount of time. And not just in trauma, but in shock in general. Because what we're really saying here is that we have a window. We have a window before our patient falls off that physiologic cliff. And ideally, what we would really like is to be the fence at the top of the cliff, not the ambulance at the bottom of the cliff. But in order to accomplish that, we have to reframe something. We really have to internalize the following. Shock is not about hypotension. Shock is about hypoperfusion. Now, we know that if you asked a test question, but we haven't really internalized it because we still believe on some very deep level that there's some direct chain together link between tissue perfusion and blood pressure. That if the blood pressure is good, we are perfusing the tissues. If the blood pressure is bad, we are not perfusing the tissues. And it turns out that is simply not true. There have been plenty of studies looking at this difference, and it turns out that tissue perfusion, independent of blood pressure, is, unsurprisingly, independently related to outcomes. It is not just about blood pressure. You can have a great blood pressure and not be perfusing your tissues. Your blood pressure can be not so great, and you're actually perfusing fine. And what matters at the end of the day? It's not blood pressure. It is tissue perfusion. That is where the magic happens. So if we all know that, I mean, at least to take a test, if you're on your critical care boards and they ask you, would you rather have tissue perfusion or blood pressure, we can answer this question theoretically. So if that's the case, we all kind of know this deep down, hypothetically at least. What is it with blood pressure? And as we said, the lovely thing about blood pressure is that we can measure it. The problem with blood pressure is that if you equate shock with hypotension, that is a great way to miss our golden hour. So what I would like us all to start doing is to start thinking better. We need to start thinking in a much more sophisticated way about shock. So, in order to get you all thinking about shock in a much more sophisticated way, I would like to present you with a cartoon. Let's take this cartoon. That is you, and that is your patient. Your patient, unfortunately, is swimming in a raging river. And your patient wants to keep swimming because at the end of that river, we have a cliff. We have a waterfall, and they don't want to go down the waterfall. So I want you all to take a minute. Picture you are swimming against raging rapids. Or if you don't like swimming, you are maybe running or biking. But you're swimming along, and you're starting to get tired. You start to get tachypnic. Your heart rate goes up. You're getting diaphoretic. And at some point, you just get so tired, you just can't keep going anymore, and you know that cliff is coming, but you're exhausted and you just can't keep going more, and this is what happens. This right here is the difference between compensated and decompensated shock. And eventually, when you are in decompensated shock, you start getting end organ dysfunction, fall off the cliff, eventually resulting in death, which is not where we want to be. And so really, the way to think about compensated versus decompensated shock is this. It is not a state, it is a balance. It is a balance between physiologic stress and physiologic reserve. And that balance is different in every patient. And this is why doing things like, you know that chart we all had to memorize in med school to pass the test that was like, if you've lost this much blood and your heart rate is this and your blood pressure is this, it means, I don't know, something. I clearly have promptly forgotten that chart because I never thought it was useful. Because what it means if I have a otherwise really healthy 18-year-old guy who's actually lost 3 liters of blood, well, he has very robust physiologic reserve under an extreme physiologic stress. On the other hand, if I have a little 98-year-old lady who has heart failure and renal failure, who's on a beta blocker and everything else failure, who has a little UTI, well now, physiologic reserve not so much, but physiologic stress also not so much. What shock looks like in those two patients is very difficult. And if you try and memorize a chart, it's not going to apply. So we have our balance. We have compensated shock, where my patient's physiologic reserve exceeds their physiologic stress. Then we have decompensated shock, where now that balance shifts. Now their physiologic stress is exceeding their physiologic reserve. What do I call this? I talk about the shock continuum. What does this continuum look like? Well, we have some inciting event, whatever it is that put our patient in that raging river in the first place. Now we have this initial state of shock, and that is a state of physiologic stress. Think about how you're feeling. Early on, you're swimming full out, you're running full out, you're biking all out. That state of physiologic stress, that state of hypertension, tachycardia, diaphoresis, physiologic stress. Now, ultimately, when your body can't handle that physiologic stress, we now transition into a state of tissue hypoperfusion, ultimately resulting in end organ dysfunction and death. And this is what I like to call the shock continuum. We can't ask, is our patient in shock, yes or no? We ask ourselves, where are they on our shock continuum? Because at the end of the day, what we need to focus on to catch our patients early is right here, this sympathetically activated state. And this is why, if you fail to understand this continuum, you will also miss your golden hour. Because equating shock with hypotension, that's late shock. Because what else happens in a physiologically stressed state? Hypertension, right? What is your blood pressure doing when you're tachycardic, tachypnic, diaphoresis? If you measured your blood pressure during that period, you would be hypertensive. And we see this practically all the time in the trauma bay. A trauma patient, lung healthy patient, comes in, and they come in, and you know that they lost a lot of blood in the field, but they come in, and they're tachycardic to the 150s, and they don't look so good. But that first blood pressure, they're hypertensive. They're like 150 over 90, and everybody gets all reassured because they're hyper, not hypotensive. That is the patient's physiologic epidrip, because they all have an endogenous epidrip. It's going bananas, right? Their hypertension from that sympathetic activation, from that physiologic stress, is masking their hypotension. Here's the thing. Like everything in medicine, just because we don't notice it doesn't mean it's not there. Your pace is in shock, whether you fail to notice it or not. And in medicine, we like to give our own misfaults names. There's a name for this. There's a name for us not noticing shock. It's called occult shock. We talk about it like it's a medical term rather than a miss on our part, when in reality, all occult shock is the physician conflating hypotension and hypoperfusion. So if I just told you that blood pressure is not a super fantastic way to know if your patient is in shock, the next question you are all very reasonably asking is, okay, if that's the case, how do I know when my patient is in shock? And I am sorry to have to report that there is no single metric, lab, measurement, score that will definitively tell you yes or no to shock. Success. Success? Yes? Success. Okay, fantastic. So what actually just happened is nobody wanted to hear that actually there's no definitive test to identify shock. You were just like, earmuffs, that doesn't sound good, that's gonna make my life difficult, let's not hear that. And I'm sorry to tell you this, because it would be nice if there was some test where we could be like, okay, if the test number is greater than 37.26, they're in shock. If it's less than that, they're not in shock. Unfortunately, that's not an option. Our only option here is to do thinking. Now, fortunately, we can do this thinking without the need of any fancy technology. We don't need a SWAN, we don't need a sublingual something monitor. All we need is a couple of basic things that are right in front of us, no matter where you are. They're right in front of us, whether we are in the ED, whether we're in the ICU, or often most importantly, if we're in the field. Now, when we are thinking about these things, the things on our exam, labs, and monitor that'll tell us when we put them all together whether our patient's in shock, we need to think about those metrics, those data points in the context of our physiologic stress, in the context of our shock continuum, because any one of those numbers can indicate one or more of these things on our shock continuum. Some metrics tell you about the inciting event. Some metrics indicate to you that your patient has physiologic stress. Others indicate tissue hypoperfusion, and eventually some of them indicate organ dysfunction. So as we talk about these, think about which one might be indicating what. So let's start with labs. Mental status. So this one we need to be very cautious about, especially with the agitated patient. And this has gotten me into trouble over and over again, especially if the patient has a psych history. But here's the thing. If you are running really hard on a treadmill and you're like, I'm really tired, I can't keep running, and somebody else is like, no, just keep running, yeah, you're going to get kind of agitated, because patients who feel like they're about to die, it tends to be quite agitating. So don't mistake this for the patient is just, having a psych issue or just like yelling and screaming for the fun of it. They're agitated. Now that's the physiologic stress response, and if they transition into the tissue hypoperfusion response and they are now hypoperfusing their brain and they do that, that's bad. That's now tissue hypoperfusion. That is the other end of the spectrum. Mental status, agitation, and also the bleh response. There's a technical name for it. I don't know what it is. All right, next, work of breathing. And what I mean here is not respiratory rate, but think about how you breathe when you're swimming or running. You don't go, you don't take rapid, shallow breaths. You're at first trying to take big, deep breaths. You use your accessory muscles. And accessory muscle use, more than anything else, makes me concerned. Now, watch how this guy is breathing. He's not super tachypnic, but look at his accessory muscles. Now, ultimately, this again, physiologic stress right here. When the patient does start taking rapid, shallow breathing, now I'm concerned, because now they cannot keep up anymore. Now I'm worried they're going into that phase where they're starting to hypoperfuse. But this is another thing we have to be very careful about for something I call the dyspnea masquerade. So this one right here, this is when we get confused, and we believe that because the patient's not breathing well, it means they have a respiratory problem, because the lung bone's connected to the can't breathe bone, and that must mean the respiratory thing's the problem. But not necessarily. And this is important to recognize, that just because they can't breathe, the patient tells you even they can't breathe, doesn't mean we should intubate them. Because if in fact they can't breathe because they're in shock, intubating them can do more harm than good. Intubating them is a great way for a clean assassination. So think about this. When you see a patient in respiratory distress, if you think it's because they're in shock, maybe now's the time to investigate, not intubate. That almost rhymes, right? I should make that into a thing if ABCs can be a thing. Investigate, not intubate. Anyway, I'm going to coin that right now. All right. Skin exam. This is incredibly useful. And this is another thing where you have a spectrum. When the patient is diaphoretic, this is our physiologic stress response. And once they progress into modeling, now they're hypoperfusing everything, including their skin. All right, capillary refill time. This is the first time that we encounter our helpful, friendly fingers, because our fingers are very, very helpful in shock. I kind of think about them as the canary in the coal mine for shock. They are the first things that get hit, because when you think about shock, what is your body trying to do? Well, it doesn't really care about the fingers. It's like, let's preserve flow to the brain, the heart, the kidneys, the fingers, we don't really care about them. So early on, we are going to see problems with the fingers. They're our early warning sign, and capillary refill is one of them. We have some data that capillary refill may be just as good as lactate when we're looking at shock. I personally think that that data may be telling us that lactate's not so useful and that capillary refill, who knows? However, capillary refill, useful thing. Labs. Oh, wait, before we get to labs, very important thing, urine output. Okay, urine output is a very, very useful metric, but it's also a dangerous metric. Why? Because the kidneys are dumb. The kidneys cannot understand why a patient's in shock. Because when the kidneys evolved, what happened was, okay, when they evolved back in the day, if they were not getting enough perfusion, it was either because you were being chased by a tiger and ended up getting bitten and were bleeding to death, or because maybe you had cholera and were having massive diarrhea. So the kidneys believe on a very fundamental evolutionary level that if they're not getting perfused, it's because they're hypovolemic. They didn't stick around for when cardiogenic shock happened. That was much later. People didn't die of cardiogenic shock back then. So urine output, a very important thing, except if you believe that no urine output means you should give fluids. That is not what it means. It does probably mean the kidneys aren't getting enough perfusion. It just doesn't tell you why. Labs. Now, some of your labs tell you about physiologic stress versus hypoperfusion. Lactate. This is an important one. Lactate is a very useful number. It's just not a crystal ball that tells you about shock. And here's the problem with lactate. Lactate cannot be used to either rule in nor rule out shock. Why can't you use lactate to rule in shock? Well, that is because it's a physiologic stress thing. Lactate is not just about hypoperfusion. It is actually about physiologic stress as well. And think about it. Somebody has massive seizure, somebody comes in on a bunch of meth, or maybe you just give too much albuterol, your lactate can go up just from that beta receptor stimulation, just from that stress. And that is why it can't be used to rule in shock. I have some more bad news about lactate. It also can't be used to rule out shock. This looked at a bunch of patients. They had septic shock. Well, they had sepsis, we like to call it. But they were sick enough that they were having organ dysfunction, they were in the ICU, and unfortunately they found the following. Nearly 50% of those patients, sick enough to be admitted to the ICU with sepsis, had a normal lactate within the first 24 hours when we are seeing this patient. You cannot use lactate to rule out shock as well. Not to mention that the other mistake we make with lactate is that we forget that a high lactate tells you absolutely nothing about why the patient may be in shock. Lactate does not equate with sepsis or any other kind of shock. It just tells you there's either physiologic stress or tissue hypoperfusion. What else? Base excess bicarb. Metabolic acidosis I find very concerning, and you can have a metabolic acidosis without a high lactate. And that is the thing that's on the top of my list that deeply concerns me when I see it in a patient who I think might be in shock. All right, white count. Here is the thing about white count. Stress leukocytosis is a thing. A high white count may tell you about the inciting event. It may tell you why the patient is in shock, that they have an infection, or it may just tell you there's a stress response. We see this in trauma patients all the time. They come in, they just had a big trauma. Their white count is 15. Did they get sepsis on the way to their car accident? Possibly, but I doubt it. Stress leukocytosis is a thing. Another thing is glucose, because stress hyperglycemia, also a thing. We see this all the time in the post-CT surgery patients. We put them all on insulin out of the OR. Why? They didn't develop diabetes intra-op, but physiologic stress states can cause hyperglycemia. And sometimes this causes misses, because we see hyperglycemia, a gap acidosis, and we're like, aha, they must have DKA. Unless they have stress hyperglycemia from profound shock, and that gap acidosis is actually a lactic acidosis. But this is, again, when our handy-dandy fingers are useful, because in addition to cap refill, there's another thing. When your patient crosses from that physiologic stress state to the tissue hypoperfusion state, now you can see something different. Now the body's like, we don't need the fingers, we'll just not give them that much blood flow. And what you can see is, in a patient with profound shock, you can actually see their finger stick glucose, not their serum glucose, but their finger stick glucose can actually be low. All right, organ dysfunction. We now have a bunch of labs that just tell us that, the organs are suffering, we're hypoperfusing them. Those are all the usual things. Creatinine, LFTs, INR. You can even get a trope leak from just physiologic stress. Your heart is working overtime. Now, what about the monitor? The monitor actually in certain ways is the least useful of these things. First, heart rate. This is an easy one. Keep in mind your patient is undergoing a stress test in real time. Now, heart rate is useful. The higher it goes, probably bad. And sometimes you'll see this thing where the heart rate's up, it goes up some more, it goes up some more right before they decide to crash on you. But if you have a little old lady on a beta blocker or any other pharmacology interfering with their heart rate, you might not see that, and that patient might crash early because they can't mount that physiologic stress response. They have pharmacologically prevented from doing so. SpO2 waveform. This is one that gets us in trouble all the time, but this is where our fingers, again, are our friends. Because what is the body doing? Not perfusing the fingers. What does that mean? You're not going to have a great SpO2 waveform. Now, this can be a particular problem in the patient who's really tachypnic, because the resident will come to you and be like, okay, the patient's tachypnic, they're working really hard to breathe, and their SpO2 is low. And you go into the room, and indeed, they're tachypnic, they're using their accessory muscles. You look at the monitor, and their SpO2 is like, 88, falling to 87. And then the next thing everybody does is they get out a bunch of other O2 sat probes, and we're like, let's try the other finger, let's try the ear, let's try the toe, let's see what happens. When what you should really be doing is putting on a blood pressure cuff and checking the blood pressure, because this is your fingers telling you you are not perfusing them. Last but not least, blood pressure. Right? I mean, it is on there. It is an important thing, but I'm including it last because it's a thing, but it's not the thing. It is a data point. It is an important data point, but it is not the only data point. So you can see from this list that there is no one single definitive test for shock. Instead, we need to be smart. We need to do thinking. We need to take all of our metrics, understand what they mean and they don't mean, understand that it's not about blood pressure. It's about looking at our metrics, thinking about our shock continuum, putting together our data points to tell us not yes or no, does the patient have shock, but where might they be on our shock continuum. Now, once we've answered the question, we think the patient's on the shock continuum, the next obvious question is why? Why is my patient in shock? And again, here is an important time not to conflate these two questions, because I often see the following. My resident correctly identifies, for whatever reason, that my patient is in shock. Pat on the back, fantastic, and the next thing they say is best give them 30 cc's per kilo and antibiotics. And I'm like, no, apparently there's a face I make that's very specific when my residents want to do that. I've stopped sort of putting my head in my hands and actually crying because they would get upset when I do that, but shock does not mean sepsis. They are two different things. Identifying that your patient is in shock, in no way have you identified why they're in shock. And this right here is the state of check. You noted they're in shock, but why? We call this undifferentiated shock when you are trying to figure out why your patient is in shock. Stay tuned if you want to talk more about that tomorrow morning at 9:30. We will be back right here to talk about how do you figure out what kind of shock your patient's in. Thank you guys for listening. A version of this lecture and lots of other stuff there. The end.
Thank you so much, Sarah. I think it's always the mark of a fantastic educator when you make a really complex topic so simple and understandable. Any questions from the audience? I can't see any hands. Any questions from the audience? Great, that means I get to ask my question. So a few years ago, we had some speakers here talking about microvascular monitoring and mitochondrial resuscitation. And I was just wondering, because in terms of medical devices, the US tends to get the best first. What's your experience of these, or what's your opinion on these?
Yeah. So, microphone. I'm supposed to. Thank you. So I think this is one of these things that in a couple years, this is going to be a very useful data point. I think one pitfall that we like to get into when we have a new test is we like to try and make it the only data point. We like to try and do studies on that test and be like, can this one thing identify shock with an AUC? That's amazing. And that's clearly not the answer. That's never the answer. So I think one of the things is just to realize it's going to be a data point, but not the data point like everything else. And two, we need to know what to do with that data, because right now it's one of those things that we get a lot of data from it, but what does it mean? So I think ultimately it's actually going to turn into a very, very useful data point. But one, it's a technology most of us don't have. Two, even once we do have it, we're going to get used to using it, and that's going to take time, especially when we have to integrate it into all of the other data points we use for shock.
Thank you so much. Anything from the audience? I guess thank you very, very much. Look forward to seeing you at the bar and at the workshops.